Management. Thank you guys for joining us today. The first thing I want to point out is on my very first slide, we have an error. And this is my fault. I jumped the gun here. This is the 2018 proposed rule. I know that it has been closed for comment since the end of June, and it has been sent on to the powers that be to finalize, but it is not finalized yet, and we will correct this slide prior to sending out the slides to anyone who attends. So I apologize for that again, and once again, this is the proposed rule for 2018. I do want to, just for anyone who's joining us for the first time, I want to tell you guys a little bit about advanced hospice management. Our focus is hospice billing, and we are a nationwide company. We service hospices everywhere across the country. We have billers who also reside in the different areas, different MACs, which gives us all a great deal of experience. We have redundancies in place for any of our clients. We service each client with a particular biller, and we also have backup billers. We have 24-hour access through our hotline. Our billing service, I believe, is second to none. So if anybody is in need of billing services, if you have challenges in that department in collections, please let us know. We would be happy to help you guys out. And now my slideshow won't work. Sorry about that. So this is everything I just said, basically. We're geographically dispersed. We really pride ourselves on education and customer service. And again, if anyone out there needs billing services or even just clarification on whether or not your processes are working for you, we would be happy to look into that for you and give you a solution that works. So I think our first topic we'll talk about is the 2018 Hospice Proposed Rule. I'll say that again, Proposed Rule. And there's quite a lot that was covered in this year's rule, and we'll talk a little bit more about each one of these topics. First will be the hospice rate and cap increase. 2016 data analytics. Medicare gave us a lot of feedback in comparison with years past. Part D spending for hospice beneficiaries, which is, as you all know, has been a hot topic in the past as well, and they've given us some numbers. Proposed change for determining hospice eligibility. CMS claims-based measures are being developed. HART, which is assumed to be a replacement at some point for HIS, and it's an expanded assessment, and we'll talk about that as well. And Hospice Compare, which is supposed to go live at the end of the summer, so we'll talk about that as well. Another issue we definitely want to cover as a billing service, this is something that of course, we are managing for a lot of clients across the country, and we want to help you guys make sure that you don't miss any of these adjustments. But MLN Matters SE 17014 was put out May 24th, 2017, and it identifies 2 additional errors. I'm sure you all remember there were some SIA payment rate errors at the beginning of our 2-tier and SIA payments. And now they've identified 2 additional errors, which were actually identified in February, but Medicare has worked to try to figure out how to make their system compliant with the correct payment calculations, and now they're saying they have a fix, but it won't be in place until August 21st. So they've given us some instructions on how we can correct our claims if we've received payments in error. So I'm going to jump right into the Hospice Proposed Rule. The 2018 hospice rate and cap increases. The proposed rule estimates a 1% increase in hospice payment and aggregate cap, and this translates to an increase of $180 million in payments to hospices in fiscal year 2018, and an aggregate cap increase to $28,689.04. This is only a 1% increase for this year only, and that's part of the macro physician payment agreement. Next year, we'll be back to the market basket calculation. And if you're not familiar with the macro physician payment agreement, it doesn't affect hospice agencies. It affects physicians, and it's a rebase of payment for them. And if you need to know more about that, I'll be happy to provide you with some links. So in the data analytics, there's good, bad, and ugly, but mostly good, to be honest. So Medicare came back with, again, the comparisons for length of stay. And we all know this is an important measure that that Medicare looks at closely for hospices. In 2015, 78 days. In 2016, 79 days. I mean, basically we're flat. I don't see that would pose any kind of probes into, any hospice claims any further than they've already done. Median length of stay really doesn't mean anything to us as far as, and I see a typo, sorry about that. 18 days and 18 days, so we're the same on our median length of stay. Also good is our live discharge rate. Medicare basically sees this as, stable. They've been about the same from 2013 to 2016. Our live discharge rate was 16.4%, in 2016, 16.9%. Of that 16.9%, 38 were revocations, which are out of the control of the hospice. 51% no longer terminally ill, stable, which is, of course, why you would discharge someone from hospice, and 11% were transfers. Also good, Medicare Part A and Part B spending on beneficiaries during hospice election periods has steadily gone down from 2012 to 2016, and in that time period, we've seen a 25% drop, which, as CMS remarks, is not a trivial amount, and they recognize that we are moving in the right direction. And this means that we are providing good coordination of care, and that we're billing timely, that other providers know the patient has elected hospice, is using the hospice benefit, and that prevents double billing. So there are not as many other types of care billing for services during the hospice election, because at some point Medicare goes back and recoups the money from one of the providers, and it's not the hospice, it's the physician or the hospital. So this really gives them a clear indication that we're doing a better job at letting other providers know that the patient has elected hospice. Let me go back one slide. I think I actually have deleted or missed the slide, but there's a couple other things that CMS remarked on that I think is notable. One is that analytics for SIA visits shows that we have not, as an industry, increased our SIA visits since the implementation of payment for those clinical visits in the last 7 days of life. Now, Medicare, I think, sees that as a good point, because they see it as maybe we are not trying to game the system, which I don't know how they would think we would do that, but I think they're always thinking that there are people who try to maximize revenue, whether it's the right way or not the right way. But it does make me wonder if the point of the SIA payment was to incentivize agencies to provide more care at the end of life. And if our visits have not increased, does that really mean are we doing that? Are we focusing on that end of life care in the last 7 days? And again, I know that's unpredictable. You cannot predict when your patient will pass away. But it just makes me wonder, do they see it in a good way, but do they see it as impetus for us to have the SIA payment to begin with? I'm not sure that we are using our utilization in those last 7 days, and as the patient declines remarkably in the last 7 days, are we seeing the patient? Are we providing enough care? Another part of that slide that I'm missing was that CMS noted that in 2016, 100% of hospice claims had more than one diagnosis. I think that's incredible. I think for years and years we went with one diagnosis code on the claim, and even though it's been restated over and over that we needed to include any comorbidities that impact the plan of care or have the potential to impact the plan of care, it seems that we are finally on board with that, and we are using more than one diagnosis. I think there are very few patients in the hospice age group or census that have one diagnosis. I know that's not true for pediatrics maybe, and a very small segment, but for the most part, our hospice patients are up in age, and I do believe that they have multiple comorbidities that impact the care and their response to palliative care. So I can appreciate that, and I hope you guys continue to code correctly and of course, following the guidelines. Medicare now states we have to code everything related and unrelated on the claim. So whatever the patient has to be documented on the claim. Bad. And I use a question mark here because I'm not really sure that this is bad. I think it may be just a change in the way we're documenting Alzheimer's and dementia in patients. So these are the top 5 primary diagnoses for hospice in 2016. 11% of patients had Alzheimer's disease, 6% heart failure unspecified, 5% COPD unspecified, 4% malignant neoplasms of the lung, and 4% senile dementia of the brain. So Alzheimer's disease is the principal diagnosis almost twice as often as the second most used diagnosis. Is that a bad statistic? Well, not necessarily. In an in-service last week, a physician pointed out that since Medicare has issued the do not code primary list, and it includes most other dementias unspecified, he believes, and I agree, that now we are using a more specific code, that physicians are having to give us a more specific primary terminal diagnosis because we can't just use dementia. So I think that may be the increase in the Alzheimer's disease as primary. And the ugly. So Part D, I think we've all discussed Part D. Back in 2014, Medicare put out a statement and did a lot of work and gave us the PA process for the 4 classes of medications most used in hospice. We were going in the right direction. 2012, hospice beneficiaries also had Part D spending in the amount of $331 million. In 2013, it went up. In 2014, finally, it dropped significantly because of the implementation of the PA process and because, I think CMS got it across to hospices about coverage expectations. But in 2015, we went up again. In 2016, we're way up to $347 million. So what changed? Well, the PA process has lowered the Part D spending on the 4 classes of medications that require a PA. But the increase in spending is a result of beneficiaries filling maintenance medications through Part D. So the patient may have brain cancer, and they're filling medications for their comorbidities of hypertension and heart disease and asthma and diabetes. And those are things that CMS cited as examples. So CMS again reminds us that the hospices are responsible for covering drugs and biologicals related to the palliation and management of the terminal illness and related conditions during the hospice election period. Part D is responsible to cover treatment unrelated to the terminal illness or related conditions while the patient is on hospice. Since the inception of the hospice benefit, Medicare has stated that it is their view that the hospices are required to provide virtually all care that is required for terminally ill patients. And CMS has reiterated this statement in recent years, and the changes in diagnosis coding requirements reflect the expectation that hospices treat the patient as a whole and not just one particular disease process. So who determines relatedness? And this is something else that was discussed in our proposed rule, And the attending physician is the only clinician who can determine and document related versus unrelated conditions with regard to the terminal prognosis. If you feel, or if your physician feels that there is an unrelated condition present in a hospice patient, then that physician needs to write a statement outlining those unrelated conditions, and that way if your patient seeks other treatment for those conditions outside of the hospice benefit, but through other Medicare benefits, Part B or Part D, then you have documentation showing that it was determined by the physician to be unrelated. And there's some pretty strong language out there about this, that other, and I want to say it was NHPCO, that I saw a webinar that said, unless there is clear evidence that a condition is unrelated to the terminal prognosis, all conditions are considered related and the responsibility of the hospice to address and treat. So we definitely want to make sure we have written documentation if we are not covering medications for a particular condition that exists in a hospice patient. Proposed changes in eligibility determination. So this is a proposed change in determining when the patient is eligible for hospice. And there's ongoing concerns by CMS regarding hospice eligibility and terminal illness documentation. CMS is considering changing the requirements for hospice certification. One consideration being made concerns hospices potentially having to confirm the terminal condition by obtaining medical records for patient care provided prior to the patient electing hospice. Their records could come from the referring physician, acute or post-acute care, such as a hospital stay, prior to the hospice referral. Another consideration is whether the patient's terminal condition could be confirmed and documented by a face-to-face physician visit prior to electing hospice if medical records are not sufficient. So I think they will do an either-or on this if it is finalized. The proposal doesn't change the criteria for hospice care, but it would change the required time frame for when the supporting documentation of terminal illness would be obtained and where that documentation must originate. So you would have to get this documentation from the physician or acute or post-acute care prior to the hospice election. Claim-based measures, another part of our proposed rule. CMS is developing claim-based measures to address avoidable hospice care transitions and access to all levels of hospice care. Hospice care providers are encouraged to assess the level of care provided towards end of life to decrease avoidable care transitions. Appropriate use of continuous care and general inpatient care improves the patient's chances of dying in the location they choose, likely at home, and also increases patient and family satisfaction. Providing the appropriate level of care to the family and support, providing the appropriate level of care to the patient and support to the family helps keep the patient comfortable and the family informed, both of which reduce ER and hospital visits. This may increase potential Medicare savings, but more importantly, it allows the patient to remain comfortable at home or in the setting they choose where their family can remain close. Considering that about 98% of all hospice care is routine, it sounds like Medicare is encouraging us to assess our patients' needs more closely toward the end of life and provide the appropriate level of care, and they are looking for ways to incentivize agencies to do so. So I believe they are certainly looking at how many patients are revoking. If you remember back when we looked at live discharges, the majority of those patients are revoking, and where are they going? I'm sure it's very easy for CMS to track. When a patient leaves hospice care, there are claims from other maybe acute care providers immediately following, and that's triggering CMS to say, hold on, is there a way to avoid that? And I do believe, of course, there's always room for Medicare savings if we avoid those acute care hospitalizations, but I also believe that with the patient's best interest at mind, they would rather the patient stay in hospice and be cared for at whatever appropriate level of care is needed. So I think that 98% of routine hospice care days tells us that we do have room for days of continuous care or general inpatient if it's warranted and needed and can be documented, of course, that we can prevent some of these other, the revocations that patients seek to go out and seek treatment elsewhere. And I know a lot of that is maybe driven by the family, for families who have never been through that, which I'm sure most families have not been through, a family member dying and declining prior to death. And so sometimes they panic. You guys all know this. I mean, it's something that we can maybe work on to help identify patients a little bit earlier in their needs and get them into the right level of care to prevent them from revoking and seeking other treatment. HART is another proposed rule. Now, this is not being proposed for 2017, but it was open for comments, and they gave us an outline of what it is. It's an evaluation and assessment reporting tool that's being developed that will first complement HIS or expand HIS, and then it will replace HIS in the future. So it will not replace your CAPS or other Medicare conditions of participation, but it's designed to improve the comprehensive hospice assessment, and it will collect expanded data sets for patient assessment, care planning, and delivery. And it may even be used for payment refinement. So this is in the works, and I was glad to see it was put out, and it was open for discussion. So if you keep an eye on that, and in fact we have some links to the agency developing this tool, so we can post that on our website or include it in the end of the webinar before we send out the slideshow. Hospice Compare. Hospice Compare is supposed to go live late summer 2017, so that is upon us. Hospices have 30 days to review the preview report, and if you find errors in that report, you can request that CMS review your report. CMS will review, and if they confirm that errors affected the measures, they will agree to correct, and they will suppress the measure on the Hospice Compare website for one time only if there's an error, and they'll also display the corrected measure during the subsequent quarterly refresh. So you definitely want to pull your reports, and you want to review them for errors, and you definitely want to contact CMS if you discover anything that you think could be an error. Hospice payment errors. So we're beyond the proposed rule, and now we're talking about the MLN Matters SE 17014 that was released on May 24th, and it outlines 2 specific errors that Medicare identified in February of 2017. And again, it took them from then until now to figure out how they could correct their claims processing systems before they gave us a date to start correcting the previous claims that have been submitted and may be paid incorrectly. So if the prior hospice days used are greater than 99, which means if you have a patient that has prior hospice before coming to your agency and those days exceed 99, the Medicare systems were processing the claims, they were calculating your claims incorrectly. So Medicare will correct its system to eliminate this error on August 21st, but they will require us to go back and review and recycle claims that may have been paid incorrectly prior to the August 21st date. They stated in this MLN Matters, on this second part, they said RHC visits, and I believe they mean days. I don't believe they meant visits, but routine hospice care days are overpaid when there's a transfer within a benefit period because the days prior to the transfer are not being recognized. Medicare will correct its system in a future release, but a workaround allows claims to be adjusted in the interim. So this specifically targets transfer patients. So this is just their reasoning. It comes right off of this MLN Matters, that they just don't have the capacity to recycle all of the claims because they can't identify which claims may be affected just based on your claims history. They have to go into the common working file. So for them to do a correction, they would have to reprocess virtually every hospice claim that's been filed. So instead of, that would hugely tax their entire system and may disrupt our current billing and payments, which would really be a mess. So instead, they're asking us to look into it further, review the common working file for each patient that we've admitted, and verify whether or not our claims have paid correctly. So, again, they throw in SIA, and we've had an SIA correction for a while, so we're going to focus on the routine home care payment errors. We can now submit adjustments to claims with outstanding routine home care payment errors, except for those with prior benefit days greater than 99. So we are going to, I have a little slide that I created, and it's actually a spreadsheet that we've created that I'll share with you guys. The transfer workaround. Hospices should apply a workaround when submitting adjustments to claims where there's a transfer in the benefit period. And for you guys who don't do billing, this just might be Greek, but it's just a matter of changing the start date on your hospice, your first hospice claim. So when you enter your claim for that first claim that you're going to submit after a transfer, we would normally put our admission date when the patient came to our agency as the admission date on that claim. And what CMS is telling us to do instead is to enter the start date of the current benefit period as the admission date. So if you're not a biller, if you have questions about this, please contact me. I'll be happy to write some examples, and I didn't for this and I should have, but it's just a matter of putting a different date there. And you may actually have to submit your claims, continue to submit your claims as they come out of your software. If you're using software, you're going to have an admission date, and it will populate on your claim. And then you can go back and recycle it as an adjustment and change that date so that you get your correct payment. Sorry guys, I went down too many slides. Okay, to facilitate processing the adjustments, hospices should add special coding to their adjustment claims. This is another just technical part of the claim process. So again, if you have questions, please contact me. You will need a condition code, D9, and you will need to submit remarks, and it should read just like this: adjustment due to RHC errors, and cite your SE 17014. And CMS did not give us an adjustment reason code, but you have to have one. So we're going to confirm with CMS that OT is appropriate. And if that is appropriate, I'll send an email to everyone on this webinar that says, yes, you can use the OT adjustment reason code on your transfer adjustments. So this is our tracking tool. This is just the heading of a spreadsheet, and it's only the first few columns of the spreadsheet, but it's basically helpful to put your patients into a spreadsheet and answer the questions as you go through. So, did the patient have prior hospice within the 60 days prior to admission or transfer, and how many days were used? And you can get all of this information from the common working file. So if you aren't familiar with it, if you're new to billing, or if you just are maybe a little overwhelmed by this, again, get in touch with us and we'll try to help you guys sort it out. This will be the best way to track. You can put a column in for when you submitted your adjustment. You can put a column in that you confirm that your adjustment processed correctly and you've received the correct payment. So this is really the best way, I believe, to make sure you've looked at every potential claim that may have had a payment error and that you've addressed it. Either it did not need an adjustment, it paid correctly the first time, or it did need an adjustment and you've done the adjustment and now you're monitoring the processing and it's paid, it's completed, you don't have to look at it again. There are not as many claims out there as it appears when you think about this, but it's going to vary by hospice. It will definitely depend on how many transfers an agency does. Sometimes in certain areas, patients tend to hop around. You get more transfers coming in or leaving out. It doesn't affect the transferring out hospice. It affects you if you transfer in a lot of patients. So you definitely want to track it all so you can make sure you've looked at every claim. And timeliness of corrections. The overpayments were made in error on the part of CMS and in the claims processing formulation, so it's not an error by providers. But CMS does expect us to comply with the instructions in the release and, to perform the required action. And while CMS has not given us a time frame, it's expected that providers process them as soon as possible. So again, get your spreadsheet. I know everybody's the first of the month, it's billing time, and it's probably not the week that you'll focus on this, but in a week or two, you probably should get your spreadsheet together, start entering your patients. You can run reports from your software to pull admits and discharges and deaths and cross-reference it to your spreadsheet. I would probably create my spreadsheet, use my reports, and enter all my patient data first. Then I would start researching on the common working file and making notes on my spreadsheet. And then the last step would be to go in and start actually processing those adjustments. So that is everything we have. I know this was probably the longest webinar. The proposed rule had quite a few topics this time. So if anybody has any questions, I'll see if I can actually see the question. Let's see. Questions. Okay, I don't see anything on here now, guys, but if there's anything that you all want to ask, or if you have questions regarding especially the billing component of this webinar, I know that, again, that for some agencies you may have quite a number of claims, and for others you may only have a few. But if you need our assistance getting started or even knowing how to review these claims, we'll be happy to put together a second webinar, if that helps, to go through just that particular process, and we can maybe do some examples and step-by-step to show you guys where to find your common working file information, how to pull your reports out of your software and transfer them on your spreadsheet. It's important. It's important that we be compliant. It's important that our payments are accurate. So whatever we can do to help you guys out, we'll definitely do that. So I have one question, just will you email the slides? And yes, we will definitely email the slides when we make that correction to the proposed rule on our title. And I will include some links to some of the other things I've referenced to make sure you guys can find, like this MLN Matters. I know we sent it in the newsletter, but we'll make sure we attach it again to the slide. So if anybody has any other questions, I don't see anything else coming over right now, but if you go to sit down and do these things and have questions, then most definitely reach out to us. So Our contact information is included in our newsletter, and it is also included on our last slide, which is here. That's my email address, the phone number. Again, reach out if we can help. And I appreciate everybody attending today. And we'll get the slides out to you this afternoon. Thanks so much, guys. Have a good afternoon. Bye-bye.